left in a previous journal club because it was a third topic and it was a big topic, and I ensured that and I promised that I will cover that topic later on. And this is a very important topic today, which I found that during ultrasound of the baby, how to see the fetal neurological system, the brain and the spine. There should be a proper method to identify the normal and to identify away from the normal. Second very important thing is how early you can find away from the normal. Most important thing in CNS is central nervous system is a developing structure, and it develops in fetus from the beginning with a different structure, and then it remodels itself, and there is a formation of lot of things, and gradually it happens and it matures, takes shape, different in first trimester, different, slightly different in second trimester, and then third trimester in adult brain. The basic purpose of doing a good fetal neuroscan is that can we identify the abnormality of the central nervous system, which is, although all systems are very important for us, for baby and for development, but nervous system creates a problem which creates lot of problems later on in the life when baby takes birth, where there is a problem with the learning disability, problem with the convulsion, problem with cerebral palsy, lot of things which can be predicted by looking at the away from the normal structure. For that we have to know the normal structure first. For that we have to know how the normal structure develops. So this International Society of Obstetrics and Gynecology, they have issued or published a guideline in 2020 White Journal. With that, there are two parts. Part one is for screening examination, that is the screening when we do mid-trimester screening and when we look at the brain. So there are different way of mid-trimester screening. One is 20+2 scan, another is following the ISUOG method, but there is a part that brain has to and the spine has to be seen in a particular fashion in a screening method. Now if there is a problem in screening, you feel that there is something abnormal in screening, then how to identify the abnormal thing, that has been discussed in part 2, that is more targeted fetal neurosonography. Now the targeted fetal neurosonography, you have to know about the brain, its structure and its development, and with the different method, different sections, the whole brain and the spine is examined. This is the basic crux of the ISUOG guideline, and I made a very simple that list that where we should go and what to be seen. This is neurosonography by ISUOG. There are two parts, one is basic, one is targeted. The basic, I will be discussing these things in detail. The basic contains transventricular plane, transcerebellar plane and transthalamic plane, and with that we have to know about the head shape, lateral ventricle, cavum, septum, pellucidity, thalami, cerebellum, cisterna magna, and with basic scan do the basic fetal spine. Now the basic fetal spine, if you go 20+2 scan, then we should do a coronal, a sagittal and the transverse of the each and every vertebrae. What is the quantitative estimation during the basic scan when we do our regular scan in mid-trimester or T5 scanning? that is atrial width, transverse cerebellar diameter, BPD and head circumference. Atrial width should be less than 10 mm throughout the gestation. Transcerebellar diameter increases by 1 mm per week from 14 to 21 weeks, and most of the time its diameter in millimeter gives about the gestational age in weeks. This is the basic thing. And the targeted one, when it comes, suppose some problem is there, so what are the indications? I will discuss when to do this targeted. It is preferred and it is recommended that transvaginal approach should be done. So it is more targeted. When we do targeted, there are 3 routine transverse planes which are in our screening plane, that is transventricular, transcerebellar and transthalamic. In addition to that, we have to do transvaginal coronal section of the brain. One is through frontal lobe, one is through caudate lobe, one is through thalamus, one is through cerebellum. Now when we do frontal lobe, we have to do the interhemispheric fissure and other things which I will discuss. Mostly transcaudate, when we do, we should see the frontal horn, cavum septum pellucidum and ganglionic eminences. What are these? I will discuss. The transthalamic, when we do the thalamus and the insula, what is insula I will let you know. And transcerebellar, we do see occipital horn, cerebellum and calcarine sulcus. This is the coronal sections. What are the sagittal sections in targeted one? One is absolutely median sagittal, but median sagittal taken as an anterior plane in the anterior part, median sagittal in posterior plane and parasagittal. So when we do median, mid sagittal, anterior plane, we focus upon corpus callosum, cavum septum pellucidum, third ventricle and fourth ventricle. When we do posterior part, median sagittal, we should see the aqueduct of the sylvius, fourth ventricle, brain stem, vermis and cistern magna. With parasagittal, we go little bit away from the corpus callosum and the parasagittal way. We should see the brain parenchyma, the lateral ventricle and choroid plexus. And during fetal spine, which also in basic scanning, there should be a transverse view of the spine, sagittal view of the spine and coronal view of the spine. With that, we can add in targeted the 3D ultrasound also of the brain, and there are recommendations of fetal MRI also. So there are 2 parts in my talk. It will be a little bit lengthy, but we have to see the brain in whole and basic scan followed by, if you can do that, then you should do a targeted scan also. So this is the basic framework of the talk and basic framework of the ISUOG guideline. So ISUOG practice guideline updated, part 1 is performance of the screening, examination and indications for targeted neurosonography. This is the part 1. I am starting the part 1. There are 2 things in part 1, performance of the screening examination and indications for, what are the indications for targeted neurosonography you should understand while doing the primary scan. The introduction, central nervous system malformations are some of the most common congenital malformations. Neural tube defects are most frequent CNS malformation and amount to about 1 to 2 cases per 1,000 births. So it is a common thing, but a lot of things while putting the probe on the abdomen of the lady in the mid-trimester scan, or even in the first trimester scan when we do nuchal translucency and all. Lot of gross abnormality you can very well know, that is anencephaly and lot of things which easily can be seen, and you can tell the patient that this is the problem for the fetus. But when there is a things appears okay, then you have to do this detailed screening. So general consideration, gestational age, the recommendation, knowledge of appearance of normal CNS at different gestational age. very very important, because there are multiple things which are present which will appear later. In first trimester it might be not be there, but later it gets remodeled, and in third trimester again remodeling, and the formation of like the communication between fourth ventricle and the cisterna magna, which is common before 19 weeks, should not be after 19 weeks. So we have to have a knowledge of normal CNS at different gestational age. For these things we need to know the embryology, which I will discuss with you. This guideline is applied during mid-trimester anomaly scan. The basic scan is mid-trimester when we do tip 5 scanning. But when we do nuchal translucency also, lot of brain substance, lot of details of the brain substance of the fetus we see. And if we know the embryology of the baby at the time of anti-scan, so we can know about what happens in 13 weeks, what happens in 16 weeks, what happens in 18 weeks. Because 18 to 20 weeks we do the mid-trimester scan. Before that, if we do an anatomical scan at 12 weeks, the things might be caught at that time there if there is a problem. If we understand, if we know what is the actual embryological anatomy at 13 weeks. Early identification of CNS abnormalities may be possible, dorsal and rhomboencephalic induction defects. These can be seen in very early part of the, like anencephaly or a lot of things we can see. The early examination of brain at 12 to 15 weeks is preferred. Now see, the ISUOG guideline tells that it is a mid-trimester scan, but in the same paper, in the same guideline, in the text, it has been written that early examination of the brain at 12 to 15 weeks is preferred. That means we should know about the basic detail of 12 to 15 weeks appearance of the fetal brain. So, if I go for the embryology, the neural tube is, brain is formed, a brain and spine is formed by neural tube. The neural tube is a single tube with 3 constriction and 1 tail. These 3 constrictions are, this is called prosencephalon, mesencephalon and rhombencephalon. These 3 parts are forebrain, midbrain and hindbrain, they make. Now what happens during the development? This neural tube has developed over the embryonic plate. Now this neural tube is having some wall also, thickness. So this thickness is the tissue which makes the neural tube. If you see this, there is one cavity inside, and this cavity is communicating from here to here to here to here. So that means there is a canal which is continuously going from the prosencephalon to mesencephalon to rhombencephalon to spine. What happens at the time of growth? There is a formation of depression from this part. So there will be a depression which is making this prosencephalon into 2 halves. So this each half will be called telencephalon. You see one part of the prosencephalon, which is the forebrain, is common here. So there is formation of 2 part and 1 common part, which is connected with this cavity and this cavity. So this is connected with this cavity, and this furrow, this depression is coming from here. That means there is one part of the brain which is just below the prosencephalon or just below the telencephalon, which is connected with. So this part is called diencephalon. After this diencephalon, there is continuity of this cavity into this, which is called mesencephalon. Mesencephalon makes the midbrain. So what telencephalon makes? Telencephalon makes cerebral hemisphere. What diencephalon makes? Mostly thalamus and hypothalamus. Mesencephalon makes midbrain. What rhombencephalon? Rhombencephalon again divides into two parts. So this is myelencephalon and metencephalon. This myelencephalon makes pons and cerebellum, and this metencephalon makes medulla oblongata. This is the basic structure of the brain when it is being developing. So if you see this cavity inside the brain, it contains some fluid, which is cerebrospinal fluid. This depression from here is taking this membrane along with blood vessel, and it comes inside and it gets over here, and there is a fluid which is coming out from this blood vessel or the tuft of blood vessels. This fluid, clear fluid, which is effusing from this, is coming from telencephalon to diencephalon to midbrain to pons to medulla oblongata and then to the spine. This telencephalonic cavity is called lateral ventricle. This diencephalic cavity, which is connecting with the telencephalic cavity, that is lateral ventricle, is called third ventricle. And gradually, if there is a modeling, so there will be two orifices from where it is getting connected, so it is called foramen of Monro. Now when it comes here, they grow and it becomes a slit like this. So it becomes an aqueduct of Sylvius. This aqueduct of Sylvius goes here, and there is again a dilatation little bit. This is called fourth ventricle. So this is a basic anatomy of embryological brain, not in a straight line, but there will be flexures which I will show there, and these flexures will have their own cavity, and this cavity is telencephalic cavity, is lateral ventricle. Then there is a diencephalic cavity, is third ventricle, aqueduct of Sylvius, fourth ventricle, and now this, if continuously generated, now there will be more formation of choroid plexus. These are choroid plexus. These are called choroid plexus. These choroid plexus, here choroid plexus. They will create a fluid which will be connected here, and it will create a pressure. To diffuse this pressure, there are places to go from here to out. These are foramen of Luschka and foramen of Magendie. These are all from fourth ventricle. When it comes out, there will be CSF outside the spine also. this spine or this neuronal tissue is covered by immediately by pia matter, followed by arachnoid matter. So this covering from ectoderm, that is dura, it can just below that there will be the arachnoid matter from neural crest, and it is covered by, brain is covered by pia matter. So there is a formation of this cavity, because this is arachnoid, this is dura, and this is covered by pia matter. So this arachnoid and pia, in between there will be subarachnoid space. So this fluid is coming from here to subarachnoid space outside the spine, outside this, and then get absorbed by through granulations into the superior sagittal sinus. I will come in later on. This is the basic structure of what is happening in the brain. If you see this is the telencephalon area, cerebral hemisphere. There is formation of olfactory lobe. This is diencephalon. This is midbrain. Midbrain has a flexure, and you can see there is formation of metencephalon, that is cerebellum and pons. The green area is myelencephalon with medulla oblongata and cervical flexure, and this part is the spinal cord. This is the basic model which is happening after neural tube formation. There are multiple things which are developing at the same time. You can see this. The same thing which is changing at central nervous system, which is at 49 days, at third month, you see what happens with the telencephalon. The telencephalon becomes a big area covering most of the midbrain, this diencephalon, and the midbrain is here. The cerebellum is developing. There is a medulla oblongata, and you can see this cerebellum. There are lips which are coming to cover this. So I will let you know what is happening. So this is the embryology, what is going on in the brain gradually. Now, if you see this part, if I cut this part, this is the prosencephalon, and it is converted into telencephalon. Now this telencephalon, there is something is going down, and this is the neural tissue, and there will be a floor of the neural tissue also just below the telencephalon. So whenever there is formation of this fissure, so this will create a connection between the two telencephalon, because it will be the connecting area, and this will be the roof of the third ventricle. This is diencephalon, and this is called third ventricle. So if you see this area of cutting the telencephalon, the lateral ventricle, the interventricular foramen of Monro, there is a roof of third ventricle, and it is going down, and formation of telencephalic vesicle, ependymal layer, there is mental. So if you see the neural tissue, which is now converted into three parts, three layers. One is ependymal layer, which is related with the CSF and cavity. There will be a mental layer, and there will be a marginal layer. What are these? I will let you know. But what is the base of this cavity is, in between there is a formation of common space, which is third ventricle, and here the formation of thalamus. So what is this corpus stratum which we see in targeted sonography? This corpus stratum is basically, this is all neural tissue. This neural tissue is more get thicker at this place. So there is a collection of neuron. This neuron is called corpus striatum or basal nuclei. This basal nuclei will again change into chordate nucleus and putamen and all, which I will let you know with the diagram. The same at 7 weeks. This was 7.5 weeks and this was in 7 weeks, and after that this 7.5 weeks. Okay. At the 3 month, the same place in telencephalonic area, what you see, there will be formation of brain superior sagittal sinus. The dura mater is divided into two, and the dura mater goes down, and it makes the falx cerebri. This falx cerebri will have a inferior sagittal sinus also. With this falx cerebri, the pia mater takes the blood vessels inside into the lateral ventricle with ependymal covering, because this ependyma is taken with the blood vessel. They make the choroid plexus. Why I am giving this idea? Because until unless you understand this, you cannot see the things when you are doing even the screening examination. When you see this part is very complex, and they are connecting this telencephalic area or cerebral cortex with connecting each other, and the floor of the telencephalic area becomes thick, which makes corpus striatum basal nuclei into mostly in two parts. One is related medially is chordate nucleus, and there will be a small area. After that, there will be collection of more nuclei. This is lentiform nucleus in both sides, and both the sides are connected by commissure. So there is one commissure here. Commissure means connection, and another connection is here. So when I do an ultrasound over here at the time of 3 months, and if I see by ultrasound through transvaginal approach, I will see thickening. I might not think this sound if the ultrasound machine is not very good in appreciating all these things and resolution wise, you cannot see, but there is a thickening. But definitely you can see both the choroid plexus, and there will be a division, there will be a falx. So when you see ISUOG guideline, you have to see the falx, you have to see the choroid plexus. If choroid plexus is visible, falx is visible, that means there is a formation of telencephalon, that is normal. If it is not there, then both the cavities will be a one cavity. Then there will be no division of prosencephalon. And if there is no prosencephalonic division, there will be all body, if our upper part from the pharyngeal arches, we grow by left and right half of the pharyngeal arches and different things, 2 eyes and all. So if this is not there, then there will be no left and right, it will be central, and there will be a one prosencephalon, that is hollow prosencephaly. The same area when we cut, there will be a area where both are getting connected. This area is called third ventricle, and this is the optic recess of third ventricle, from where the optic tract will develop. I am not going into that detail, but even with the good machine you can see the optic tract also. So this is, if you go more in detail at the area where this place, I want to make it more clear, is that these are all telencephalonic area, and this is the falx which is coming in between. So when there is a falx is coming and there is a connection of both the telencephalonic area, this part is called corpus callosum. And when you make a corpus callosum, there will be a formation of a membrane below the corpus callosum which divides the lateral ventricles. This lateral ventricle become 3 parts, that is anterior horn, temporal horn, posterior horn. when this is divided by this, you can see in between a septum. This septum is septum pellucidum. So if we see septum pellucidum, and in the early part of the pregnancy there will be an area between the two membranes, that is called cavum septum pellucidum. So if cavum septum pellucidum is visible, that means there is corpus callosum, and if corpus callosum is there, that means there are two telencephalic area and brain is developing normally. And these choroid plexus, they will grow into lateral ventricle. If you see, the corpus stratum becomes divided into body of the caudate nucleus, and there will be internal capsule, and this is called corpus stratum, claustrum, and different part. This is putamen and lentiform nucleus. And this area, when we do a coronal section, or we can see there is a depression in the cortex which is called lateral sulcus. Very, very important. And this lateral sulcus is gradually depressing, gradually going down this deep, and there is a folding of upper and lower and formation of area which is covered by upper lip and lower lip. This area is called insula. When you go down, this part, which is the lower part of the cerebral cortex, anterior part, very different areas and sulci and gyri can be seen, which can be seen in a little bit advanced brain, and this is called amygdala. I am not going into, but if you can come to this part, which is the central part, you can see two thalami, and between the two thalami there is a interthalamic bridge, which adhesion, and in below that there will be a formation of third ventricle. Below that, the hypothalamus. This, the area where the neuron tube is made up of. One is the outer part where the pia is marginal layer, this mantle layer, and neuroepithelial, and this is the internal limiting membrane, from where the neurons are degenerating and they are migrating neuroblasts towards the periphery. This arrangement of the neurons are very, very important for normal brain development. And this cerebellar hemisphere develops like this. I can give you the detail if you ask me, but I am not going into the detail. But this is the cerebral hemisphere at third month. This is the arrangement. This arrangement is very important. If there is no proper and there is a migrational defect, then there will be a lot of problems. So what is the migration of neuron? Now brain at 6 months, how it looks from outside. So this is a very important sulcus, which is sylvian sulcus or lateral sulcus. In between you can see an island, below is insula, the olfactory bulb, and formation of telencephalic brain, cerebral hemisphere. The midbrain is, and this diencephalon thalamus is inside, covered by this temporal lobe. Below that you can see the myelencephalon, pons and cerebellum, and this is pyramid, and this is medulla oblongata from metencephalon and spinal cord. This is the basic arrangement of the brain which happens in fetus at 6 months. Now we see this either through transverse section from here, or from here. So from here you can see the lateral ventricle plane. Just below that there will be thalamic plane, because thalamus will be there. And if I cut like this, then I can go in transcerebellar plane. So this arrangement has to be in your mind while doing the ultrasound, because this three-dimensional approach has to be, otherwise you cannot make it out what you are seeing. So it at 9 months it becomes a little bit more bigger, multiple sulci and gyri. I am not going into that detail, but this is the arrangement. And this is the fully developed adult brain. Now, if I cut that brain transversely, what we can see? You can see there is a division between two telencephalic area. You can see one cavity which becomes very small because all neuronal tissue has grown and made the cavity small. So basically this was the neural canal, which is now converted by this parts into two-part lateral ventricle, and there is a one common ventricle that is called third ventricle. And these are all thalamus. If you see, this cavity is going behind. In this lobe is the lateral ventricle. This area is the atrium, where we measure the atrial width, lateral ventricular width. And when you go down, this part is connecting two hemispheres. This will be corpus callosum, and this is the corpus callosum. So the corpus callosum is going like this. So this part is very, very important, and with the corpus callosum as a roof, you can see one membrane is hanging upon it. This is septum pellucidum, and below the septum pellucidum it is held by fornix. So these arrangements we see in our transverse section of fetal brain. Now how this corpus callosum looks? Corpus callosum will be like this. Corpus callosum becomes, first it will be very small connection, then it will grow as the brain grows, then it will be a fully grown. The fully grown one will have rostrum, genome, body and splenium. Now this part will have one hemisphere here, one hemisphere here. So there is a connection between to this. So this is the part of the corpus callosum, very important. And if you see the corpus callosum from above, you can see there is a cavity below this. This cavity is, this is fornix, and there will be, this is corpus callosum. This corpus callosum has splenium, rostrum, genome and body. This is after 19 weeks or 20 weeks fully formed. If you see, there is just below that there will be septum pellucidum, and between the septum pellucidum there is a cave. This cave is called cavum septum pellucidum, and this septum pellucidum is still here up to this. This is thalamus, and after that it will cavum vergi. So this is the arrangement which is, if you cut this section sagittal. So I cut this section sagittal. So this is anterior, this is posterior, this is corpus callosum, and you can see this is the fornix, and from where this area is lateral ventricle, which is connecting with the third ventricle. The third ventricle goes through the aqueduct of Sylvius into fourth ventricle, where the cerebellum has developed, anteriorly pons develop, and this is middle of the mirror. This depiction is creating CSF from here, which is converting, going through the foramen of Monro into the third ventricle, and from third ventricle to aqueduct of Sylvius into fourth ventricle. And you can see there are foramina, which are orifices which gives the place to depressurize the CSF fluid into outer part of the neural tube. The outer part of the neural tube is external to the neural tube through this foramen of Luschka and foramen of Magendie. You see the Magendie is placed below the cerebellar hemisphere, and this is the fastigium. This is the top area of the fourth ventricle. Now this is coming into this neural canal. Neural tissue is covered by pia mater. This is arachnoid, and this is coming into subarachnoid space. This subarachnoid space is going through here into arachnoid granulation, into superior sagittal sinus, into the brain, these veins. So there is a formation of CSF, and then it goes. When we do sagittal section of the fetal brain, this is an adult brain, but most of the things are in 19 to 20 weeks. We can see this. So this arrangement has to be seen. This is territorium cerebelli, and this area which is going through is subarachnoid space. Now this area of subarachnoid space, you can see lot of big spaces like here, like here, like here. So these spaces, which are the bigger spaces, are called system. The name of the systems are given according to their, like quadrigeminal system, the ambient system, the cisterna magna, and these are the area of subarachnoid space. These has to be known before doing an ultrasound in fetal brain. And this is the posterior part of the fetal brain, where the arrangement of cerebellum, the cerebellum is cut sagittally. The sagittal part of the cerebellum, this median part is called vermis, and these vermis is having a different fissure and different area. If you want to go study, and you can see these lobes also. These are the different lobes, but there is a one called tonsil also here in cerebellar hemisphere. This tonsil goes when there is a leak of CSF, and this tonsil goes through foramen magnum. When it happens, then it gets blocked. This is called cherry tube malformation. So you have to know about, this is the vein of Galen, and this is the arrangement. Now I am coming again into actual transventricular normal morphological changes of fetal brain throughout gestation as visualized on sonographic examination, axial plane, that is transverse plane. View is transventricular. Now what happens in 12 weeks? Falx, choroid plexus, falx. Now choroid plexus becomes small at 21 weeks. 32 weeks changes. There are multiple things which I have shown through anatomy, that there will be falx cerebri, the anterior horn of the lateral ventricle. This is anterior horn here. This is cavum septum pellucidum, and this is the atrium. So you measure this atrium at the lateral ventricle. Same thing what happens in 32 weeks. So there is a continuous change in transventricular area. But this is very, very important what we do in screening examination. That means if there is a cavum septum pellucidum, that is CSP, thalamus, that means there will be corpus callosum. If there is corpus callosum and cavum septum pellucidum, so that means the prosencephalon has been divided into two. So chances of having gross prosencephaly, the hollow prosencephaly, will be out. So same thing when we do screening examination, transthalamic, what happens in 12 weeks? You can see there is a big space which is aqueduct of Sylvius, third ventricle, and you will see the falx. But this falx and this choroid plexus gives a very good comfort that the brain is developing normally. The same thing when we come into 21 weeks, which is the T5 scan or target scan, you can see there is a depression. This is called lateral septum, and you can see a lot of things. The cavum septum pellucidum is still there, but this cavum septum pellucidum is not very good visible in the mature brain. So don't worry about that. But there are other things which should be. And the transcerebellar plane, the transcerebellar plane, if you see in 12 weeks, very difficult to see, but you can see there is formation of choroid plexus of the fourth ventricle. If there is a formation of choroid plexus of fourth ventricle, that means the cerebellum is forming. And just behind this is developing cisterna magna, and just below that formation of fourth ventricle, that is called internal translucency. And when we do 21 weeks scan, this is the scan when the mid-trimestral scan is being done. You can see again lateral sulcus, the two cerebellar hemisphere. This is the vermis, and you can see two membrane which is interrupting the cisterna magna, which is normal, and this box is Blake's pouch, which is normal, which breaks down and makes the foramen magnum. This cavum septum pellucidum is visible, should be visible when we measure this, and you can see the posterior part of corpus callosum. So these are thalamus. In between the thalamus there is this third ventricle, which is not visible but visible by all these white lines are actually covered by pyometer, which are reflecting surfaces. So we can make the brain anatomy by these lines, and this area is subarachnoid space. Same thing when 32 weeks the cerebellum is developed with lobes and foliars, it is already gone, and you cannot see very well the cavum septum pellucidum. So technical factors: ultrasound transduction, maybe 3 to 5 transabdominal transducer, wide band transducer, imaging parameters, grayscale, 2-dimensional, USG, and harmonic cross beam. So I will cover this topic now fast because we have covered the anatomy. The screening examination at fetal brain after 18 weeks, quantitative, 3 planes already described, spine and 3 planes. Now we have to see this thing in screening examination, that is head shape, lateral ventricle, cavum septum pellucidum, thalamine, cerebellum, cisterna magna, and spine. And these are the different planes which I already covered, and these are the things which is visible while we do this transventricular, this is transventricular, transcerebellar and transthalamic. So the transventricular recommendation: aspect of atrium distal to the transducer and the presence of cavum septum pellucidum. Anterior and posterior portion of the lateral ventricle, they have a well-defined lateral wall and is separated medially by cavum septum pellucidum. Already I discussed all these things, and failure to demonstrate CSP prior to 16 weeks or later than 37 weeks is normal finding. So these are the main the things which are important in transventricular plane, and there has been name has been given the anterior complex and the posterior complex. The CSP caudate nucleus I already described, has to be seen. If you can see the importance of visualizing in CSP, already discussed, there will be failure to visualize membrane, a lot of highly suspicious of number. These are the things which you, when we get that CSP is not visible, cavum septum is not visible, go for targeted sonography, because it goes in favor of complete agenesis or partial agenesis of corpus callosum. Posterior portion of lateral ventricle, atrium and posterior horn, and posterior portion of the lateral ventricle, occipital horn. Already I covered during the anatomy. The transcerebellar, this is the anatomy of cerebellum, and I already covered the rule of thumb is by 19 weeks there should be no midline fluid filled space between the two cerebellar hemispheres. That means the vermis has already covered the area, and there is a clear demarcation between cisterna magna and fourth ventricle. If it is present, may be associated with anomaly of cerebellar vermis and referred to neurosonography. Transthalamic area, the thalamic plane, these are the mostly we do the measurements, and if you go little bit slide caudal, the interpedicular and ambient and squatogenital system along with the cerebral peduncles can be seen. Cerebral peduncles are midbrain. Now fetal spine has to be seen, and to understand whether there is any problem with the 3 ossification center and intactness of the skin overlying the spine by transverse or coronal or sagittal. So this is, if you do a little bit detailed scanning, you can see the conus medullaris which at the L2 and Using an ossified spinous process of vertebral acoustic window, contents of neural canal can also be seen. And this is the very important of transverse section of each and axial view of all level. The quantitative evaluation, atrial width, biometry and transcerebellar diameter increased by 1 millimeter per week. And this is the measurement, how to do a measurement of the lateral ventricle has been given in ISUOG guideline. And this is the best way at where the parotoccipital sulcus is there at mid gestation, and take the glomus and the lateral ventricle. Low risk mid trimester pregnancy. This is a very important statement. If a low risk mid trimester pregnancy, if the transventricular, transcerebellar planes are obtained satisfactorily, the head measurement, head circumference in particular, are within normal limits for gestational age, the atrial width is less than 10 millimeter and the cisterna magna width is between 2 and 10 millimeter, many cerebral malformations are excluded. The risk of CNS anomaly that can be diagnosed at this gestational age is exceedingly low, and further examination are not indicated. That means if you do a good screening with knowledge of anatomy at a different stage. So screening examination of fetal brain before 18 weeks, recommendation is that screening ultrasound examination is carried out before 18 weeks. Effort should be made to visualize and document the transventricular and transcerebellar plane. Now this is again at 16 weeks what to be done, because we are reaching as early as possible to know whether the things are normal or abnormal. So this is the best way to know the anatomy and embryology. What is the targeted neurosonography? The targeted neurosonography focus in this guideline is to describe the protocol for diagnostic ultrasound examination that should be performed in any case in which there is an increased risk of CNS malformation. So there are multiple indications, and these indications have to be kept in mind while we do our screening examination. If there is a problem, we should go for targeted sonography, and the transvaginal approach is the best way. But if it is breech, then we can do a transabdominal also. So axial, coronal and sagittal planes, as described part 1, these guidelines. So fetal vein, variety of scanning veins can be used depending upon the position of the fetus, and I have already covered all these anatomical plane, 4 coronal and 3 sagittal, along with the 3 axial plane basic screening. Apart from anatomical structure, fetal neurosonography should also include evaluation of convolutions of fetal brain which change throughout the gestation. Now this is very important. This is the area where the coronal section at frontal. This is coronal section at caudate nucleus. These are the caudate nucleus. This is corpus callosum. This is tabum septum. And again, if you go below the transthalamic plane, and this is transcerebellar, you can see the cerebellar hemisphere also. And these are the method by which you can see the anatomy, and these are the anatomy which should be visible to you. And if you go transfrontal, you can see the olfactory sulci also, because they are going just below the frontal lobe. And transcaudate already covered. These are the cross section of anterior part of the body. This is transthalamic plane in a coronal section. The transcerebellar plane, depending upon the visualization of the occipital horn of the lateral ventricle and the interhemispheric fissure. Both cerebellar and the vermis are seen in this plane. The vermis is more echogenic than this. Already covered, and these are all transcerebellar plane which can be seen at 21 weeks, 26 weeks and 31 weeks. So these are all the things where development of calcareous sulci. This is the calcareous sulci which is going inside the occipital horn. And this is the sagittal plane, 2 sagittal planes, one mid sagittal and one parasagittal. This is the mid sagittal where you can see the corpus callosum in 4, the anterior part and the posterior part, and the parasagittal. So I already covered that supra and infratentorial anatomy, corpus callosum. Biometry, component of corpus callosum are visible sonographically normal. So these are the things which are in targeted sonography, and median and median or mid sagittal anterior plane. These are already covered. I have shown this, the mid sagittal, what is available when we do this in our ultrasound. And infratentorial anatomy, that is below the tentorial cerebellum, the vermis and the fourth ventricle, and median or mid sagittal posterior plane, where we do the detailed analysis of cerebellar vermis and the pons and fourth ventricle, and the degree between brainstem and the vermis, whether there is a deviation of the vermis or not, formation of vermis or not. So this is all the anatomical midline landmarks of the vermis and posterior fossa can be studied thoroughly using this approach. These are the things which we can see. You can see in the diagram. We can see this while doing the posterior mid sagittal section, and this is the parasagittal and parasagittal planes, the choroid plexus, the different periventricular brain parenchyma, mainly the third. Lot of gyri and sulci we can see, and insula, salient fissure, and more lateral view will be the visualization of the temporal horns of the ventricle. So this is the way we do our targeted sonography. The additional planes are, we can take those additional planes also, and the fetal spine has to be done in a 3-plane to be seen in detail, what already has been told in screening examination. And again, if you can do a detailed examination of the cord, you can see the chorda equina also. So using the 3-dimensional ultrasound, we can take the spine in a very nice way. Use of 3D ultrasound approach is recommended in targeted sonography. And these are the 3D method. You take one view and you can get 3 orthogonal views. This is cavum septum pellucidum. This is cavum vermi. So this is the section of the spine. Neurosonography at 30 to 17 weeks. Very difficult. You have to know the detailed anatomy at the time of fetal brain at 30 to 14 weeks, because there is a rapid change and the very researches are going on what is the things which are present in 13 weeks or not. So this is the detailed neurosonography at 13 weeks. You can go into that publication, and it has been given in ISUOG guideline very nicely, and we can do that while doing the MT scan. We can see these things. This is the aqueduct of Sylvius, this is falx, thalamus, midbrain, this is the cisterna magna, and this is formation of the choroid plexus of fourth ventricle. It's the same way in a section. This is the choroid plexus of the fourth ventricle. This is developing cisterna magna and fourth ventricle. So this is internal translucency. In the same way, you can take this section, and this is the bar of choroid plexus. This is fourth ventricle, and this is cisterna magna. These are all neurosonography at 15 weeks. Thank you very much for your patient listening. And this is a very big topic. I have covered more on anatomy, and if you take this anatomy and read this ISUOG guideline, it will be easy to understand what the ISUOG guideline is telling us what to do and what to see. Thank you very much for patient listening.